I'm pleased to introduce Dr. Gillian Murphy. Dr. Murphy has had over 25 years of experience in the field of crisis intervention and is a leading expert in suicide assessment and intervention practices for crisis services. In her previous role as the Assistant Deputy Director for the National Suicide Prevention Lifeline, now the 988 Suicide and Crisis Lifeline, she oversaw the development of national standards of excellence and clinical best practices in suicide prevention for phone, chat, and text-based services. She currently maintains a private practice as a licensed social worker in New York City, providing CBT and DBT-informed care to individuals at risk of suicide. Dr. Murphy?
Hi, thank you so much for your introduction. So I wanted to focus my presentation today on some of actually the practical aspects of suicide assessment and prevention in a clinical setting. And in particular, I wanted to reinforce the real need for training, not only in screening and assessment and intervention, but also just on the sort of engagement of those at risk of suicide through open conversations and an increased comfort in talking about suicide with individuals that are at risk. And so I also should say in advance that while I'm going to reference the 988 model here, I am not here as a representative of 988. That was my previous role, so I want to make sure that that's clear. So before we even begin, actually, I wanted to sort of revisit the core statistic that we heard at the beginning of the Dr. Jacobs' presentation, because I think that, when we look at this number, 49,000, over 49,000, and this is a preliminary data for 2022, and that refers to the number of people that die each year by suicide. And I tend to think that whenever, I want people to really sort of think about that number, because I tend to think whenever I do a presentation, I sort of use that number as, I run through statistics as sort of an introduction to the topic. I never really stop to really think about that number and think about how many people that really is. If we think about a presentation or a conference meeting, you could have 50 people in a room. Sometimes you do a large presentation, it's a couple of hundred. But if you stop to imagine 49,000 people that are in one place of all ages and walks of life, that are really in so much pain that they would rather take their own lives than continue for one more minute. And I find when I stop and think about that number is really, really overwhelming. When we look at the literature, and we talked a bit about this just now, but when we look at the literature, you see that a lot of people who die by suicide were seen within the health and behavioral health care system within a year prior to their death, and many also within about 30 days prior to their death. And this has led to many suicide prevention efforts, public health approaches that focus on increasing public awareness of suicide, promoting universal screening in healthcare settings, and also really promote the training of clinicians in the community in suicide assessment and intervention. But I would say that despite all of the focused efforts on really trying to educate the community around suicide risk, that there are significant gaps in available well-trained clinicians. And to me, I noticed this gap more significantly, of course, in my own practice in the community. And there's thousands and thousands of private practice clinicians, psychiatrists, psychologists, social workers, and more, that if they're not connected to a large healthcare system, they can really be out of reach of any large-scale training initiatives that are focused on improving care. And for me in my practice, I often get calls from individuals who say that they have reached out to 3 or 4 or 5 different clinicians before reaching me, and that as soon as they mention either a history of suicide attempts or potential current suicidal ideation, that individual would not accept them into their practice. And myself, when I try to refer people out often, either to additional care through a psychiatrist or another community mental health clinician, I find it really, really challenging to find someone who will take on into their practice someone that is potentially at risk. And it's not that I don't understand this. I do understand. I recognize the reluctance to work with a client that you feel maybe that you're ill prepared to really work effectively with. But I also know that if you work in the field of healthcare or behavioral healthcare, you will at some point be talking to someone who expresses thoughts of suicide. And so having an understanding of what you can do at those times in those moments really has the capacity to save lives. And so I often present to groups of clinicians the assessment and interventions that I was very accustomed to in the work of the National Suicide Prevention Lifeline, which, as Doug mentioned, is now the 988 Suicide and Crisis Lifeline. And it's just one way that I've used to guide clinicians in how to really focus on maintaining the safety of their clients. But it is an approach that I think is very useful and very effective for clinicians. So I also talk about 988 as an approach because it's also, in fact, one of those systems where there is access to trained clinicians. And that access is available 24/7. To know, I'm only going to be able in this presentation to provide a sort of a higher level overview of the way in which the crisis centers are trained in the assessment and intervention of suicide. So I hope that even in this sort of higher level presentation of those training initiatives that people in the presentation today find it useful. But the 988 Crisis and Lifeline Network, it's a network of over 200 crisis centers nationwide. It's not just one central call center, which some people believe that it is. And the network of crisis centers, and it's probably even more now, is all made up of independently owned and operated crisis centers. So they are responsible for all of their own training initiatives, management of the crisis center staff that are there. But centrally, the 988 Suicide and Crisis Lifeline, if you want to be part of that actual network, you are required to adhere to specific clinical standards that have been established. And those standards specifically include suicide risk assessment standards that were initially developed in 2007, imminent risk guidelines that were developed in 2011. And they focused on how to really engage an individual in talking about suicide, how to ask effectively about an individual's risk for suicide. And once you had established that, what if there was imminent risk or high levels of risk? What would you then do? And what were you required to do in order to provide what was referred to as the least invasive intervention for that individual? Those guidelines were subsequently updated in 2022, and they are now collectively referred to as the Lifeline Suicide Safety Standards. And the policy for that, you can actually find that online, either through 988 or I believe through SPRC or Zero Suicide. And another thing that individuals that are part of the system are required to do is that they are required to train all of the staff that answer phones, texts, chats in a Lifeline safety assessment model. And that sort of puts into practice all of these individual standards and really focuses, again, as I said, on engagement, on collaborating with individuals that have contacted 988. And to work with them to establish an intervention that is the least invasive and that allows the individual to participate in sort of what the outcomes will be once they have disclosed their thoughts of suicide. It's really about the focus for crisis centers, I would say, in sort of one sentence, is to focus on working with the individual themselves to establish safety for now, to move away from a focus on how do I talk to this person and try to predict outcomes, but how do I focus on talking to this person and engage them in efforts at suicide prevention and immediate safety. So the safety assessment model essentially looks like this. It's divided as we train individuals into three distinct phases. So the first phase focuses on connection, as I said, establishing rapport. And again, this is a high overview because each of these little elements in here, the little dots on this diagram, are exploring these sort of sections in depth. But the model is really set up to focus on, for crisis centers particularly, to focus on the call flow. So initially, there's a real intent and training on how do you engage someone? How do you comfortably have a conversation about suicide? Of course, that you want to assess immediate risk. Is this person at risk in this moment? The second phase is really the central assessment phase. And that's what I focus on most when I talk to clinicians in the community. And that assessment phase focuses on listen to the suicide narrative, listen to what this individual is saying, clarify what they are saying, and then plan for safety. And when we look at that, and of course, actually, the third phase goes into offering follow-up and then wrapping up the call. But if we look back to the central assessment phase, it's focused here again on allowing the person to tell their story while also gathering information about the individual's suicide desire, their intent, their capability, and then what buffers or safety measures are possibly in place. And here we see a little bit more detail because what we refer to those elements within that listen section are what we have referred to for some time as the 4 core principles of suicide assessment. And those were developed within the Lifeline. But these core principles, Doug had mentioned earlier on the work of Thomas Joyner. And these individual areas, 4 core principles, draw on the concepts of the interpersonal psychological theory of suicide that was developed by Thomas Joyner, which proposes that it's the combination of suicidal desire with intent and acquired capability that's associated with a heightened risk of suicide. So Joyner's theory proposes, and this again repeats a little bit of what Dr. Jacobs referred to, but it proposes that it's the combination of feeling like a burden to others or feeling intolerably alone or being socially alienated that leads to a desire to die. However, the individual will not act on that desire unless they have the capacity to overcome the instinctive drive for self-preservation, and that is the fear of death. So Joyner talks about this as acquiring the capability to die. And this capability develops with repeated exposure to painful or fearful experiences, which can create what he refers to as habituation. And that's a capacity for self-harm. And if we look at the content of these sections, the desire, as I said, is feeling a burden to others. The intent is intent to act on it. You see here attempt in progress, and that of course refers to when crisis centers are assessing somebody who's not in the same location they are, whether or not this person's actually started an attempt even before they contacted the Lifeline. And I would also say that the way that the crisis centers look at their assessment is very relevant to clinicians in the community who now very often are not in the same location as a client and do primarily video-based or online interventions or assessments. The capability, of course, is the fearlessness, which always includes past suicide attempts or self-harm, where you see that someone has already passed that threshold of being able to inflict some harm on themselves. So let me move. If we, as we try to guide crisis center staff, we pulled those 4 core principles back to looking, into a table where we could then take all of the various range of risk factors that we had guided crisis centers on, and sort of risk factors, warning signs, things that they needed to know about suicide risk. But we grouped them into these 4 core areas to provide sort of a more useful and usable framework through which they could do the assessment process. So for clinicians or crisis counselors, from the moment someone says, they are having thoughts of suicide, particularly if you're sort of sitting in a location with someone as a clinician in the community, as maybe a private practice clinician who's working with someone long-term, and suddenly they start to disclose thoughts of suicide. Rather than trying to think through all of these risk factors or think through, or maybe, pull out the CSSRS, which most people in the midst of a discussion are not probably going to do, you start to really think about, does this person have desire, intent, capability? So for me in my practice, if someone has started to express suicide desire, I might ask them about that desire on a scale of 1 to 10. And if they say, they might say, oh, it's like a 7 or an 8. And so they have a strong desire. But I might also then ask them about, what about intent on a similar scale? Where do you fall on that? And maybe they say a 3. And that's okay with me. It's not that I'm going to not continue my assessment, not continue to focus on all of the other elements that I need to hear. But it tells me in that moment that the intent is low. And because what I'm really looking for is an interaction between desire, intent, and of course, then their capacity to act on this. And so when I know the intent is low, I can explore their capability and capacity, but I can also really take my time to engage in a conversation about these thoughts of suicide and let that person know that it's safe to talk about these things and we can have this conversation. And I think it opens up a lot of that conversation and allows someone to feel that you are not someone that's going to be overreactive and that they can really explore what's been happening for them. And that they can talk openly about what's been happening without fear, which some people have, that clinicians are going to immediately jump to an intervention. And of course, capability, of course, I want to really reinforce. More than anything, when I talk about capability, I'm talking about access to lethal means. And that for everyone, just no matter where their intent lies, is something that is really essential, of course, to address. And so again, the reason I find it grouping this way helpful is that, again, I don't have to sort of go back and focus on, sort of getting anxious or feeling like, oh my God, what do I know about suicide risk and what are all the things that I've learned, that I need to now implement? But that for clinicians who may not do this as often as others, that they can think, okay, desire, intent, capability, what do I know about these things? And so, for example, if you look back on the model itself, somebody in you're talking to may say, yes, I'm thinking of suicide. And so we focus on guiding staff then to listen again to this narrative. We want clinicians in the community that are not as used to talking or doing a suicide assessment to develop a comfort in actually having that conversation and not panicking, which is what many people will do. I don't say that sort of, again, flippantly. I think it's very easy, even when you've worked in this field for a very, very long time. It's very difficult to actually say the word suicide when you're talking to someone, even for myself who talks about this all the time. Sitting with a client that I may know that I've not had this conversation with, you really can hear this sort of nanosecond pause before that word can sometimes come out of my mouth. But what I want clinicians to do is to have the capacity to just sort of lean into that and say, yes, okay, I hear that you're having these thoughts. Tell me more about that. And as you listen, to be listening in your mind for desire, intent, capability, and taking note of those things as the person talks. As you're gathering information, we're teaching crisis counselors all the time to gather information in a way that informs what will be the safety plan, what will be the actions that they take later. So when the person tells their story, you go back and then clarify, what do I need to know about an individual's preparation or plan, which would be intent? What do I need to know about their access to means? What about safety measures that are in place? Clarifying these things. And then, of course, planning for safety, developing a safety plan with everyone who may at any point indicate that there's a potential risk for suicide. And that, of course, is so essential because we know that very often we do not have the capacity to determine how people move down that pathway from ideation to action. And so people who have any thoughts of suicide at all really need to have a safety plan in place for when that may suddenly switch. And also formulation of risk. When I talk to people about the formulation of risk, what I'm really focusing on and what I really guide people in is not just a determination of high, medium, low risk, but to think of it also in a two-tiered sort of stratification system where you're thinking of both acute and chronic risk, and that an individual could have potentially high risk. They might check all the boxes that indicate high risk, but it's chronic. You're not actually concerned that they are at imminent high risk. And so you need to be able to determine outcomes based on what potential label you might give someone. Formulating risk is only ever as useful as the action that you know that you are going to put into place. This I will not go into in detail. I don't have time. It's just one version of a stratification table that has been adapted from the Rocky Mountain version that you can see. There's a link here. It's just adapted. It focuses in on elements that I talk about, desire, intent, capability. But the more important part is on the right-hand side where clinicians should put in what are all the things I need to do in those moments and how do I ensure that I'm taking action in the least invasive manner and that I have belonging to my practice, things that I can do. So they can sort of fill in numbers, places that they may call people that they may engage so that they have a specific, almost private practice safety plan for themselves. That I think people find reassuring, that they know if this happens, this is what I will do. I just wanted to, I know I have just a couple of minutes, and I wanted to just loop back, and I'm sorry I could only provide such a high level overview, but I wanted to just really close and loop back on the need to fill in these gaps in care. When I talk to clinicians in the community, I'm talking to them because I just want to be able to have clinicians talk about this issue. We want to go back to really focusing on how do we expand the reach of these trainings and do what Zero Suicide refers to as training a competent, confident, and caring workforce. And the safety assessment model I use, it is not something that is designed for community-based clinicians. It's focused on crisis centers and crisis counselors and a hotline approach. But it is, I think, useful for clinicians in the community, and that's why I talk about it. I also think that, one of the things about the 988 system and the Lifeline is that it does actually have reach. Every single crisis center in that network, and there are thousands across every state, has been trained in how to talk about suicide, assess suicide, and intervene when someone is at imminent risk. And they are all trained because essentially they're required to be trained because of what they do. But I would also say that in that context, that clinicians, behavioral health clinicians in the community, should also be required in the context of what they do, to be trained in this, to be trained in having a basic competence in suicide assessment and a comfort in talking about suicide and asking these questions. And a training that allows them to focus on safety now for this individual who's in my care. How do I ensure that they are safe right now? And of course, that they have sufficient training to have this conversation and use that conversation to instill hope in the individuals that they're working with. Because ultimately, that's, I think, the sort of core focus for all that we do.
We do want to squeeze in some questions because your presentation presented a lot of great information that's prompted all kinds of questions to come in. Are you ready to tackle some of these?
I hope so.
Okay. A viewer asked, can you please share the process of what happens when someone calls 988?
So as I said, I'm not a representative of 988. I do encourage people to reach out and get information directly there. But I can tell you that when you call 988, in terms of process, the individual is going to first focus on engaging whoever calls on why they're calling, what's going on for them. They are going to listen to if the individual has thoughts of suicide, and they're going to have conversations with them and try to assess that risk. Very often, it's not a high percentage that are going to have acute suicidal ideation when they call, but there, of course, is a percentage. And they will assess for risk. They will use the least invasive intervention to try to make sure that that person is safe. But they will, at the end of the day, if they think that if they don't intervene and somebody may subsequently die, they will do everything they can to keep that person safe.
What is the evaluation process like for crisis workers? What tools do they use?
So many crisis centers use varying tools. So we have the Lifeline developed guidelines and policies, right? So it never prescribed a specific assessment tool. It sort of wanted to move away from the way in which people might have this, tool. Originally, when they were taking calls, they might have a tool that they would use. They wanted to move away from sort of check boxes that a crisis counselor might begin to focus on. So to focus less on trying to sort of predict an outcome where you get a certain score, say, and it says, call 911 or intervene right now. We wanted them to be more engaged in the conversation. So individual crisis centers have policies, and they are consistent with things like the CSSRS. So many crisis centers might also have the CSSRS in their clinical documentation, but the guidance that we're providing is sort of overarching and including those concepts. So they're not required to use a specific assessment tool.
Here's an interesting question that just came in. Are callers routed to a local crisis center? And how do you manage this when people are using a mobile phone with an area code that is no longer where they live?
So that came up very often. Yes, they are routed to local crisis center. That was always the goal, that people would receive services in the location in which they are. But that is challenging. Everybody now is on cell phones. And so it is a fact that if a cell phone has an exchange that is a California exchange, but they're actually in New York and calling from New York, that is very complicated. I don't want to speak about the systems that have now been put in place since the transition to. There was a tremendous focus on attempting to actually be able to locate and work with telephone companies to be able to actually locate a person independent of the exchange from where the phone itself is coming from. But I really can't speak to systems that have changed or been put in place in that system. But it is an issue, or has been.
Gillian, one of our viewers wants to know, outside of being in acute crisis, what are some examples of situations that are considered appropriate for someone to contact 988?
Again, I would refer you to 988 to talk about that further. When I was with the Lifeline, it really was anyone who was feeling a level of discomfort, anxiety, depression, anything where they felt a situation where they were having real difficulty coping. It does not have to be that you're in the midst of a suicidal crisis. It does not have to mean that you have active thoughts of suicide. You may have had thoughts of suicide in the past. You may not be having them now, but you feel you really need someone to talk to. Crisis counselors on the lines will talk. They will ask you, are you having thoughts of suicide? They're required to ask you that. But if the person says, no, I'm not, that's fine. They will just continue to talk and assess what's going on for you right now. Why do you need to talk to us?
Would you describe the key elements of an effective safety plan?
So I do. I think I might have a link to a safety plan, and I encourage people to go online and look at the Barbara Stanley and Greg Brown safety plan that's available. And there are trainings online that will show you all of the elements that are included in that and how to really engage an individual in that discussion. So I encourage people to look at that. It's really looking at there's 6 elements of it. It's really looking at what sort of are warning signs for you that you might be getting maybe dysregulated, or you might be getting might not be doing well, and how to engage both activities that you might do to soothe yourself, how to engage friends and family, how to engage professionals, how to keep your environment safe. So it goes through sort of steps like that, ultimately ending with, calling potentially you're the clinician you're working with, and then potentially needing to go to an emergency room. But it goes through steps. The reason it's valuable is it gives people things that they can do prior to getting to the state where they might need to go to an emergency department.
Viewer wants to know which EMR for private practice mental health clinicians has the most effective suicide risk assessment tool.
I don't know.
That's a fair answer. If virtually assisting someone has low intent but access to lethal means, such as firearms, how do you work with that person on safety plans / access to weapons?
It's a difficult one. And I think there is going to be some limitations in what you can do, but the conversation has to be had. The conversation has to be had about whether there are guns in the home and or other access, other means that somebody may have discussed. And a focus needs to be placed on how to restrict access to that, how to engage other people. So if there's other people available, I would engage them. If you're a clinician and you're working with someone and you're engaged with them remotely, you should always have an emergency contact with that individual regardless. And if that individual that you're talking to was not able to work with you on reducing or containing that access, my next step would be to reach out to whoever else is involved in their care and then go down the usual steps depending on how I have formulated that person's risk.
Let me squeeze in one more question. What are some useful trainings for suicide assessments for individual organizations?
I encourage people to go to the Zero Suicide site. Training, as I said, a competent and caring workforce is a real essential element of the Zero Suicide approach. And there are lists of many available trainings that organizations can look at and access. Again, it's not that trainings don't exist. There's many excellent evidence-based trainings. It's more that the reach, if you can imagine, how do you train every single person that you need trained in suicide assessment? And I really want to reinforce what I believe is the most essential way to train, which is which I'm sorry, but I meant to say in my presentation, and I think I skipped it, is the use of continuing education credits. Like, unless we require training in graduate programs, which even on itself I think is not sufficient, unless we require continuing education hours for anybody that's involved in behavioral health care, that they absolutely must have continuing education in suicide assessment. I think until that happens, it's going to be extraordinarily difficult to extend the reach to all clinicians across states.
And Gillian, before we wrap up, I do want to squeeze this in as well. This is a comment. I don't have a question, but I have practiced calling 988 with many adolescent patients and found it very helpful. The clinicians have always been so great at reassuring patients, and it's a good way to guide patients through this. Would highly recommend practice when you're providing patients with 988.
Good.
Gillian, we are out of time. You were fabulous with covering so much ground. Thank you so much for your time. I appreciate it very much.